Hello, everyone, and welcome to this teleconference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Casey Minnis, Director of Communications for MS Focus, and I'm joined by Dr. John Schafer, who is Director of the Mercy MS Center, MS Achievement Center. This evening, he'll be talking to us about new treatment options for multiple sclerosis. We're very excited to have him join us. And Dr. Schafer, I turn it over to you.
Thank you very much, Casey. It's very nice to be here and see all of you across the whole country. I'm in California, and I know we're stretching the whole time zones. So we're going to talk tonight about treatment options for multiple sclerosis, including some of the new. But I think to understand the new, we really want to talk about what we mean when we say treatment for multiple sclerosis. What is it that we're treating? So first, just a little bit of background to understand what it is that we're talking about treatment. What is multiple sclerosis? The important facts in talking about treatment are that women are a lot more likely than men to have MS. The most common age of onset for the first symptoms is 29 years of age. The course after onset of MS is remarkably variable, ranging from very benign course to severely disabling in other people. And the course is very difficult to predict, especially at onset when the person develops those first symptoms. Life expectancy in multiple sclerosis is only mildly affected, and so what that means is that MS is really a disorder which begins in the prime of life and is lifelong. Now, I can't stress enough the importance of age as a factor in making decisions about treatment of MS and about where it's going to go. When a colleague will call me up and say, gee, Dr. Schafer, I have a question about a patient with MS, first thing I always ask them is, how old is this person that you're going to talk about? Because if we're talking about a 32-year-old with multiple sclerosis and a 62-year-old with multiple sclerosis, these are very, very different situations. So let's review what is multiple sclerosis. And here's a slide that I'm sure that you've all seen in the past that shows the effects of what happens in multiple sclerosis. Now, on the top here, it says normal myelinated axon. So this is a nerve cell. This is the cell body, and this is the axon is the wire that runs through the brain and the spinal cord, and then it connects up with another nerve cell, another neuron farther on the line, and this is how nerve signals travel from one neuron to another. And the little sausages that you see here, the yellow sausages, are myelin. And myelin is an insulating material that's wrapped around that axon or nerve fiber. And we know that in multiple sclerosis, the pathology is that there's damage to the myelin. So in the second section here, we see an acutely demyelinating axon, and here the white is or the yellow is missing, and so the nerve signal has a very hard time traveling along this little segment here. The nerve fiber can make some accommodations so that the signal can sometimes get through, but not normally, so that the conduction along this segment is impaired. Now, not only does the myelin facilitate the conduction of the nerve impulse, but it also nurtures the nerve so that it keeps alive, so that when that myelin is gone, the nerve cell actually then may shrivel up and die, so that a nerve cell which has lost its myelin for a long period of time will actually involute and die. which is an important aspect when we're talking about treatment and putting myelin back on nerves. Now, while the nerve cells in the brain and in the spinal cord and in the optic nerves are the target of the damage in multiple sclerosis, MS is really a problem with the immune system. The thing that's causing that damage is the immune cells in the immune system. This is a schematic that's highly, highly simplified. You've seen many variations of this, and I like this one because it's one of the simplest. And over on the left-hand side, it says systemic circulation. And I'm trying to find my cursor here. So systemic circulation. So this is the bloodstream here. This is the blood-brain barrier or the lining of the bloodstream of the artery, but this area out here, it's the bloodstream. And these are lymphocytes, these two things, the T cell and the activated autoreactive T cell are lymphocytes. Lymphocytes are one of the key components of the immune system. And lymphocytes are like police cars and the police force that are cruising around the streets looking for trouble. And the immune system, its purpose is to get rid of stuff that doesn't belong there. So viruses, bacteria, cancer cells, even dead cells, when these lymphocytes see those things that don't belong there, they react. So the lymphocyte on the bottom here that says activated, this lymphocyte has been taught to look for something that doesn't belong there. Now, these lymphocytes then get into the brain, and this section on the right-hand side is the central nervous system or the brain. And here is where myelin lives, and so when these autoreactive T cells see myelin, they think that it's something that doesn't belong there, and so it seeks to destroy the myelin, and it does that. All of these other things, the cytokines and astrocytes and microglia, are all part of the apparatus that damages the myelin. So we believe that this is the scheme of what's happening in multiple sclerosis. Now, those cells that I showed you were labeled T cells. There are different kinds of lymphocytes, and this is a very fascinating part of what we've learned about multiple sclerosis, even in the last 10 or 12 years. It used to be thought, as in that slide, that it was the T lymphocytes that are the lymphocytes that cause the damage. And basically that's true. The T lymphocytes are the lymphocytes that are out on the front line causing the damage. B lymphocytes have different function, and we've known for a long time that B lymphocytes work in a different way. B lymphocytes make antibodies, and the antibodies then cause the problems. So conditions like myasthenia gravis or rheumatoid arthritis or lupus erythematosus are all conditions in which B cells produce antibodies. We never thought B cells had anything to do with multiple sclerosis until about 10 years ago, when it was discovered that B cells are necessary for the T cells to cause their damage. So B cells kind of train the T cells. So if you get rid of the B cells, or if you suppress B cells, then the T cells can't cause their damage. And so rituximab and ocrelizumab and Mavenclad are examples of medicines that suppress B cells. So why is this important? Because there are different ways that these various medications treat multiple sclerosis. It's also important to remember what is the course of multiple sclerosis. And here's a slide, again, that you've all seen before. And the important part of this is that line in the middle here, this black line that shows attacks of symptoms. So when the line is flat here, meaning that the person has no symptoms, they're normal, and then here one day you wake up and there's blurring of vision in one eye and they lose vision completely in that eye. But then after a few weeks, it comes back and it may get back to normal, and the symptom goes away as if nothing had happened. But in multiple sclerosis, we know that there's a risk that there's going to be more problems that occur. And so a short time later, and I'm having trouble bringing my cursor back again, that there may be another attack. And this attack may affect the ability to walk. And as you can see, the line, again, it may improve, but it doesn't necessarily get back to normal, and then so on and so forth. And there can be these blips of new symptoms that come along. And this is relapsing remitting multiple sclerosis. This is the most common form of multiple sclerosis, and this is the way multiple sclerosis begins in most people, with attacks that come that improve either partially or completely, but then are followed in most cases by more attacks of the same or different sorts of things. Now, after this happens, and this is usually 10 or 15 years later, many people who have gone through this relapsing remitting phase go into a progressive phase. And what that means is that even in the absence of attacks, now in this slide it shows that there are still some blips up there, but the important part of this is that there's kind of a gradual worsening, pretty much always involves the walking. It may involve cognitive functions or other things, but there's a continuous worsening even when there's no attacks occurring. And that is progressive multiple sclerosis. And just other elements on this slide, that dotted line, that the arrows on the bottom are new spots that show up on the MRI scan. The dotted line above those arrows shows the total number of MS plaques. The red line shows shrinkage of the brain, which occurs in everybody, but in MS may be more rapid. So it's really important to distinguish that there is two different processes that are going on in multiple sclerosis. One is the exacerbating remitting disease that is usually there at the beginning in younger people, and the other is that there is the progressive phase that may come on later, and in some cases, MS may begin with that progressive phase. And these are very different, these two different phases. When you look at it under the microscope, they're different in terms of what kind of cells are there causing the damage. The MRI behavior in relapsing remitting MS, when somebody has a new attack, usually you can see that new attack on the brain scan as a new MS plaque that shows up. Whereas in progressive MS, there are not new spots, so that, for example, I'll tell somebody, gee, I have great news, your MRI scan today looked no different than your MRI scan 2 years ago. There's no new plaques there. And the person says, well, geez, doc, 2 years ago I could walk and now I can't walk. So something is happening. And indeed, in progressive MS, there can be worsening of the symptoms, but even in the absence of new things showing up on the scan. And again, age has very important implications here, because the relapsing remitting is what begins in young adults, and the progressive phase in most people comes on more in midlife and in upper years, and that's true whether it's secondary progressive MS or primary progressive MS, which means that it begins as a progressive process even without any attacks in the beginning. These are really confusing terms, secondary progressive and primary progressive, and we'll talk about that again when we talk about medications and what medications have been approved by the FDA for. But I think the bottom line is that whether there's activity there, whether the immune system is causing attacks with exacerbations, or whether this is kind of the aftermath with no new activity from the immune system, but just loss of function. So hopefully we can understand that a little bit better as we go along here. Alleviating exacerbations of MS is kind of the grounds of treatment, and this really hasn't changed a whole lot over many years. That when someone has an attack of multiple sclerosis, that waking up one day with a loss of vision in one eye, and then it gets worse over a few days, and after a couple of weeks may turn around and get better, and the improvement may occur even without any treatment. But we know that steroids usually turn things around a lot more quickly than they would without the treatment. And so generally when somebody's having an exacerbation of multiple sclerosis, we give corticosteroids to restore function as quickly as possible. It used to be that this was given intravenously and that you had to be in the hospital to get this. In this day and age, it can be given as an outpatient, and we can give it by pills. There are methylprednisolone or dexamethasone pills have the same properties as solumedrol, which is given intravenously, and the pills work just as well, and you can pick it up at the drugstore on the way home from the office rather than having to be scheduled at the hospital, and they're considerably less expensive. And then there are some other treatments. So occasionally, if things are really severe and the steroids don't help, plasma exchange and IVIG may help to alleviate an acute exacerbation. So we're talking about the acute attack, not the long-term treatment, but the acute attack. Up until 1993, although we had steroids and ways of dealing with that attack, we didn't have any medications at all that would affect the long-term course of it, so that you could help somebody through an attack, but there was no relevance to whether they were going to have more attacks or how they were going to end up in 5 years or 10 years or 20 years. But since 1993, there have been an increasing number of medications which do reduce the risk of further attacks. They reduce the risk of new spots showing up in the MRI scan, and they reduce the risk of going into that progressive phase that for many people occurs later on, or at least in the past for many people occurred later on. And it's become very clear to us, not long after these were first developed, that taking these medications early provides the greatest benefit rather than waiting. So here we are with the medications. More than 15 different drugs have been approved by the FDA for the treatment primarily of relapsing remitting MS. Here are some of them. On the left-hand side here is 1993. The first medicine was beta-seron, and then you'll recognize the name of medicines that you're taking, and then here's an extension of that kind of leading right up to today. So these are the medications we have, and it can be very confusing in this forest of options. So just to kind of review what these are, we refer to platform immune modulator medications. So all of these are medicines that affect the way the immune system works. They don't necessarily suppress the immune system, but they change the way the immune system works to decrease the likelihood that that immune system is going to cause damage like we saw back in that early slide. So the platforms are, number one, beta interferons. Now, beta-seron and Avonex and Rebif and Extabia and Plegridy, they're all variations on the same medicine, the beta interferon. Then in 1997 came Copaxone, Glatopa, and glatiramer acetate are other forms of it. And these are all very similar in that they're injections that one gives oneself. There's been more than 20 years experience with them. There's a very low risk of any serious adverse effects, which has been wonderful, either in the short term or the long term. They're rarely going to cause any other problems, and they're moderately efficacious. What that means is that they reduce the chances of having more attacks in a lot of people. But what we find is that even on those medications, there are some individuals that may still have exacerbations despite those treatments. And so then kind of came another wave of medications, these intravenous ones, Tisabri, Lemtrada, Ocrelizumab. Each of these are given intravenously, and in fact, then there are some oral medications, and here are, to name a few, the Gilenya, Aubagio, Tecfidera, Mavenclad, pills that are don't have to be given by shots or infusions. And I think across the board, all of these tend to be more effective in the sense that a larger number of people will be prevented from having more attacks. And it's important to stress that all of these medications work, and there may be differences in how they work for different people that affect the choice of them, but across the board, some of these newer ones are more likely than older ones to reduce the chance of the new attack. It doesn't mean that the older ones aren't beneficial. I have lots of people who are on the older medicines who've done very well on them, and there's no reason that we would need to change those. So the newer medications do carry some more risk. I mentioned that those platform drugs, there's really essentially zero worry about is it going to affect your liver or your kidneys or your bone marrow or make you have any other diseases. And I think that with the intravenous ones and with the oral ones, there are a greater number of considerations. So there's blood tests that we do to look for any side effects of these, although by and large they are pretty safe. These are the newest medications. Vumerity. Vumerity is a twist on Tecfidera. It's very similar to Tecfidera, but it has a little bit less of the gastrointestinal side effect. Cladribine or Mavenclad is a medicine that was used to treat cancer for many years and also has a benefit for multiple sclerosis. And it's an interesting medication in that you take a pill daily for 4 or 5 days, and then a month later you take the pill daily for 4 or 5 days, and that's it for the year. And then the next year you repeat that, and after that you may not need further treatment. Siponimod and ozanimod, Mayzent and Zeposia, are newer medications that basically are variations on Gilenya. Gilenya and these medications work by preventing the lymphocytes from getting out of the lymph nodes where they're made and getting into the bloodstream. And so if those lymphocytes can't get out into the bloodstream, then they can't get into the brain to cause damage. And the difference between these different medications is how much effect they have on other organs. The way they work on lymph nodes, there are receptors in the lymph nodes that respond to these medications, and those receptors are also present in other organs in the body, and so these newer ones have less effect on those other organs. There's an asterisk there by Mayzent because the dosage of that may vary depending on one's genetic makeup. And then there's always lessons to be learned about the medications. It's exciting to see new things that come along, but then we always kind of hold our breath. I think we learned that with Tysabri that came on the market, and it was extremely effective, but it wasn't on the market very long before we realized that there was this viral infection, the PML, that occurred in some people who were taking it. And so it was taken off the market for a while, and then during that time, we figured out how to predict who was at greater risk for developing a PML and ways of prescribing it with much lower risk. And then a more recent one, Zenbrita, which is diclizumab, came on the market and was on the market for about 2 years before it was taken off the market because of liver troubles and some encephalitis. So I think with all the medications, when they're new, we're excited by them, but we always maybe hold our breath for a bit till we see what they're like out on the open road. So when should one treat with any of these medications? And what we've decided is that most with clinically definite relapsing remitting MS should be treated with immune modulators as early as possible. Again, we're talking about relapsing remitting MS, the kind that occurs in attacks, that if you give the medication early on, there's a reduction in the risk of having more attacks and a reduction in the risk that person is ever going to go into a progressive phase, all of which means that there's a much greater chance that in midlife and in later life, that person will be free of disability from MS. Now, there are a few caveats here. Clinically isolated syndrome. What about when somebody has their very first attack of MS? If we do an MRI brain scan and see that there's really no other MS plaques there, then we can monitor it clinically and watch and repeat MRI scans to see if new activity is occurring before starting the treatment. But when someone has the first attack and we do an MRI scan and we see that, lo and behold, there have been previous attacks, or if there's abnormal spinal fluid in people who have had a first attack, then we can predict that there's a greater likelihood that there's going to be more problems, and so it may be time to start the treatment. Radiologic isolated syndrome is an interesting concept that's come up in recent years. People go to the emergency room because they have a headache or they hit their head or for any number of other reasons. And the MRI scan, when you look at it, says, holy smokes, there's spots here that look a lot like multiple sclerosis. Now, technically, you can't say that person has multiple sclerosis if they've never had any symptoms or signs, and in most cases, we wouldn't treat that, but we do find that that some percentage of people who have these scans will go on to develop multiple sclerosis, and so it requires careful monitoring. Here's a graph that shows the effect of treatment. Now, on the left-hand side there, the wheelchair up at the top and the man walking with a cane in the middle and the man walking normally at the bottom, that axis is the degree of impairment. So the higher on that line, the more impaired somebody is. And then the other axis is, of course, over time. And what it shows, the red shows that if if no treatment is given, that the natural course of this is that over time, more and more people will develop increasing amount of disability and end up in wheelchairs. In the green, this is what we say, that if we begin the treatment early on, that a lot fewer people will have less impairment over that same period of time. And then the yellow is if you treat later, but not too late, there's still some benefit to the treatment. So what about progressive MS? What we've been talking about is relapsing, remitting multiple sclerosis. And there are really two different categories of progressive multiple sclerosis. As I said before, secondary progressive MS is what we call it when people have had attacks early on, so that an attack when they're 30 years old, and then another attack when they're 32, and then recurring attacks, and then in the mid-40s, that person develops just sort of gradually worsening difficulty walking. And this would be called secondary progressive MS. Secondary because they started out with relapsing, remitting, and then became progressive. What we know is that some people, a smaller percentage of people, will never have attacks, but just have a progressive trouble walking. And this is, for an example, would be, and it's a little more common in men than in women. And so men who tell me that, 2 years ago, I noticed when I was playing softball in the summer league that I was having trouble running like I used to. And then last year in the summer league, I had a lot more trouble walking, and I was even having trouble walking when I wasn't playing softball. And then that difficulty walking just gets worse and worse over time. And this is what's called progressive MS. And there are a lot fewer treatments that have been shown to be effective for progressive MS. Some of these newer medications, like the rituximab, the Ocrevus, the alemtuzumab, the Mavenclad, may have benefit to progressive kinds of MS. I think a question here, before I go to this slide, is the confusion about secondary progressive and primary progressive. In a lot of ways, these are kind of artificial terms that are used by the FDA to decide who can get a medication. I think many neurologists question, is there a difference in what's going on between primary progressive or secondary progressive, that progressive may be progressive, so it may be less clear whether one medicine is effective for primary progressive and another for secondary progressive, or how those relate. But that's something that you need to talk to your doctor about. So again, factors which affect which medicine do we pick to treat people: age, how long you've had MS, level of physical impairment. Does a person function quite normally, or are they a more advanced stage in wheelchair or bedbound? And then what the course has been since onset. This is an important thing. When I see people that have had MS since the 1980s, but they function pretty normally or have minimal symptoms, even 20 or 25 years later, that person has a much better shot at dodging the bullet and dying of old age without disability than the person who's in their 30s and is having recurrent attacks. There's been a rule of thumb in the past that's not entirely true, but in general that MS may show early on, like in the first 5 years or so, you may be able to tell where somebody's going to end up. That people with closely spaced attacks or bad attacks early on, particularly if they're on a medication, have a much greater risk of being disabled later on. And then, of course, there are other medical problems, things that would affect the response to treatments. So let's just talk a little bit about this, and I'm going to move through this more quickly because I'm sure there's going to be some questions about this. What about putting myelin back on nerves? Back at the beginning when I showed the myelin, I raised the question of, if the nerve cell has already died, is there a benefit to putting myelin back on? But still, the concept is there that if you can create myelin and make the nerves develop more myelin, is it helpful? And there have been some clinical trials in that regard, and but those clinical trials, anti-LINGO antibody is a molecule that the production of myelin. There is a LINGO molecule that puts the brakes on myelin production. And why is that necessary? Because the myelin makes itself, it wraps around the nerve, but it has to know when to stop. If it didn't, we'd all be a big ball of myelin. And so there's a switch that turns it off. So this is a medication that turns that switch off so that the myelin will produce itself. And there have been some trials with optic neuritis, but even those have been given like early on when the demyelination is first occurring, and which is a different situation than putting myelin back onto a nerve that's been without its myelin for 10, 15 years. Remyelinating antibodies, drugs that encourage myelin growth. These are all areas of research that will hopefully bring us some results. I want to say just a little bit about stem cells. Stem cells is a very exciting field. There's enormous potential there. And MS and stem cells have been used in multiple sclerosis actually for a long time. Ironically, even before we had any of these drugs, there was investigations of using stem cells to treat MS. There's two different ways that stem cells are used in multiple sclerosis, and this is very important to understand. We said that the multiple sclerosis is caused by a corrupted immune system, where those lymphocytes that we saw in that early slide are attacking the insulating material, the myelin. And so they're doing bad things. They've been taught to do bad things. So one theory is that if you got rid of the immune system and brought in a new immune system, would it be kinder? I think that's maybe like talking about the government, that if you don't like the government, just vote everybody out and vote in a whole new bunch. Will that solve all your problems? Well, it actually may in things like multiple sclerosis and in other conditions, sometimes malignancies. If you get rid of the immune system and put in a new immune system, it can be helpful. The other way that we talk about stem cells is for fixing the damaged nervous system. And in the first cause, replacing the immune system, this actually works. It's been used, and there are a number of trials, and it is effective. But what it involves is destroying the current immune system with radiation and with chemotherapy, and then you introduce the stem cells, which then build a new immune system. The problem with that is that there's a lot of risk to that the side effects may be considerable. When you do away with the immune system, there is a period of time when one is subject to infections, and it doesn't necessarily fix the damage that's already been done by the multiple sclerosis. And the bottom line is that it really does the same thing as our medications do. What we found is that stem cell ablation or immune ablation and stem cell replacement is helpful for young people with relapsing, remitting multiple sclerosis. And that's what we have found the medications to be helpful for. As I said, the stem cells were actually developed before the MS. Drugs came around, but back in the 1980s, there were a lot of restrictions on research with stem cells, so it hasn't been until more recent years that the research has gone on. And ironically, in those same years, have been developed all of these medications, which are also very effective. So right now, the million-dollar question is, which of these is better? Is stem cell replacement of the immune system better than the medications? Are the medications just as good and safer than stem cells? And all of that is being worked out right now. Stem cells to repair the damage to the nervous system is a lot more iffy. And certainly there's a lot that you read about this on the internet, and I know that I have patients who have pretty severe impairment who are anxious to get stem cell treatment, hoping that it will repair that impairment that they have. But I think that's a lot more questionable thing, and I don't think we're totally there yet. Stem cell science is exciting and may bring new options for treatment, but we do feel like these should really be done in clinical trials at this point in time. And then there's other measures: vitamin D supplements, diet, other vitamins, antidepressant medicine, and a whole long list: biotin, turmeric, exercise, therapy, other kinds of treatment that we really don't have time to get into today. What do we not know about MS treatment? We've learned a tremendous amount about treatment, and people with MS are much better off in this day and age than was the case 20 years ago, particularly those who are developing their MS now. So then the question, as I said earlier on, that there are medications that seem like they're helpful for a greater number of people, but do have more side effects. So there's a controversy within the field of multiple sclerosis about what should you give that 30-year-old woman who's walking in the door with her first attack of optic neuritis? Should we pull out the most effective medications that have a greater risk of side effects, or should we start with the older things that are much less likely to harm and may be helpful to a lot of people? And so this argument wages on, and there's no answer to it yet. The other important thing is, how long do we need to continue the treatment? As I said, it's been well shown now that in the era of these treatments that a lot fewer people are developing secondary progressive MS than was the case 20 years ago. Is there a particular time of taking the medication that accomplishes that? If you put somebody on one of those injectable medications and they do well for 10 years or 15 years, can you take it away and have them still enjoy that benefit that was conferred early on? We don't know the answer to that. We don't know when is it okay to stop giving the treatment. And there are even some trials that are in process right now, and that's something that you may want to talk to your doctor about. We do know that the older one gets, the lower is the risk of having attacks. And there have been some studies from the Mayo Clinic, for example, that look at people developing progressive MS and finding that, beyond the age of 70 or early 70s, that if you haven't become progressive by then, that you're not going to become progressive. But again, this is something to talk about with your doctor. how do you talk with your doctor? Let's talk a little bit about that. Things that you should tell your doctor at each visit. And when I see people, for their return visit, I want to know, have there been any new symptoms since the last visit that might be signs of multiple sclerosis? Or are there any, is there any worsening overall? I always ask people, how are you today compared to the way you were a year ago? How about your walking? How about your cognition? How about your dexterity of your hands? Is there anything that was easier for you a year ago than now? That tells whether someone is having progression. And then, of course, are there any new medical problems or medications that you're taking unrelated to the MS? Also, I think it's really important to talk to your doctor about what other things are you doing for your MS. Are you taking supplements? Are you taking particular diets, physical conditioning? Everybody's got their ideas of what are helpful things for MS, and it's a good thing to let your doctor know about that. You can ask your doctor, how much experience and training has your doctor had with multiple sclerosis? Does the doctor have a small number of patients with MS or a lot of patients with MS? And how about with the different medications? Does the doctor have experience with the different ones of these many medications that we talked about? And also, I think it's fair to ask your doctor at the end of your next appointment, Doc, what are your greatest concerns about me and my MS? How do you think I'm going to do? And are we playing our cards right here to reduce the chances of having more problems? So I think that these are some ideas that I hope are helpful to you. Picking treatment is a really tough choice, with so many options available and differences among different physicians. Again, I think to summarize, all of the medications work. They're helpful. There's advantages or concerns about each one of them, and so in a way, it's really great to have as many options as we do, since we can really accommodate the treatment for each individual. So with that, Casey, do we have questions?
We have a question from Charles. Charles, you're on the line. Go ahead.
Hi, thank you. Dr. Schafer, this is Charles, one of your patients. During your early in the presentation, you talked about the T cells going after the myelin. I was curious, why does it pick a certain myelin in certain nerves, and why not just go for all myelin in the whole brain?
So, Charles, that's a terrific question. Well, myelin is on nerve cells in the brain and in the spinal cord and in the optic nerve. There's also myelin on the nerves that are in your arms and your legs. But that myelin is not affected in multiple sclerosis. There are other diseases like Guillain-Barré syndrome in which the myelin and the nerves in your arms and legs are affected by the immune system. So there's something different about the fingerprint of those. So the T cells are looking for specific markers that distinguish, that tell them that this is a myelin that they're supposed to destroy, and those can be very individual, very subtle things. And there's a great deal of research, in fact, going into what is it about a particular type of myelin that makes the T cell think that it doesn't belong there.
Thank you, Charles, for your question. All right, and we have a question from Stephen. Stephen, you're on the line. Go ahead.
I was diagnosed almost at 70. Now I'm going to turn 71. The neurologist said you're not really eligible for any medications because, because of your age, and the immune system just naturally flattens out by the time you get to your age. On the other hand, I've run into other neurologists that say, no, they've been fooled and they never remove people from medications. And so I'm just kind of very confused and not sure who to believe.
So Stephen, do I understand that you've had MS for a longer time, and now you've turned 70, 71, or the MS first appeared when you're 70, 71?
First appeared at age 67, so I've had it for 3 years.
So you are an outlier. So not many people develop MS when they're 67 years old, but we see it. And I think that that's a very tough question of how long would one continue the medication. And I think that it depends a whole lot on what's happening with your symptoms and whether things are getting worse, and also what your MRI scan shows. I mean, it's we repeat MRI scans periodically to see if new activity is showing up. But I think that this is a tough situation to know, especially when it's later on in life that this occurs. How long do you need to keep taking the medication?
Yeah, and one of my takeaways from your presentation was, the statement that you really don't want to wait to start medication. It's much better if you started ahead of the rationale for needing it.
Can I ask you, when you had your first MRI scan when you were 67 and developed these symptoms, what did it look like? Did it show that there was a lot of MS activity there?
There definitely were some lesions in the spinal cord and the brain. But I had one recently, which was 2 years from the prior one, and that showed no progression at all. So right now it seems to be very stable, at least in the MRI.
I think the point that I was making is that a lot of times, particularly when one's first symptoms are at a later point in life, that the MS has actually been there for a longer time but was never causing any troubles, and then for whatever reason, something happened that caused the symptoms. But back to your question about treatment, I think that that's a difficult thing, and something that, to talk, you say your physician thinks that you don't need treatment because of your age. I'm sure that there are some physicians that consider that, but others may not look at it that way. You may want to get another opinion from, I don't know if you're seeing a neurologist in a multiple sclerosis center.
So the one I'm seeing, he's very experienced, and he sees only he has 200 MS patients, and he sees them exclusively. So I think he's very deep in the disease. The other opinions I'm getting is when I go to certain gatherings where there's, say, a neurologist that, like yourself, that's presenting, and then is taking questions. I'll ask the question, and again, I get a very different answer.
Yes, and I can understand that, and I would say that you may want to get a different opinion from another neurologist, not just at a pharmaceutical dinner, but at a face-to-face with a neurologist, and it may be the same. They may agree. There are many, many things about your situation that, of course, I don't know. What your scan looks like, what other things look like that could affect that. But it's a heavy question and an important question of whether you should be on a treatment or not.
Thank you for that question, Stephen. All right. We have time for just one more question. We have a question from Miriam.
Oh, great. I'd like to ask if there's a standard of care for how often people should have MRI scans.
Good question, Miriam. How often should one have an MRI scan? The National MS Society has said, kind of blanket, that people should have an MRI scan every year or every 2 years. And I think that the vast majority of doctors who deal a lot in MS don't necessarily agree with that. Early on, an MRI scan is very important at the time of diagnosis. And then when we begin treatment, we usually will repeat an MRI scan in a year or even as short as 6 months or so to see whether that medication is becoming effective. And then after that, it's a lot more up in the air. I have people that have had MS for 15 years and are fine on their treatment and, haven't had any new symptoms at all, and they're on a medication that I have high regard for. And I may repeat their MRI scans every few years just to make sure that there's not activity going on that we're missing. If we're only looking at the clinical part of it. So, regrettably, my answer to that is it varies a whole lot, depending on how long you've had your MS, how well you're doing. And another thing is, I have people that have scans every 3 or 4 years, and there hasn't been any change in their MRI scans over a period of 10 years. And so, I feel less pressure about doing another scan on somebody like that if they're not having any new symptoms. So thanks for that question, Miriam. Is that helpful to you at all?
Yes, thank you very much.
All right. Thank you, Miriam. I just want to take a moment before we part to let you know that if you missed any part of this teleconference, that it will be available on the Foundation's YouTube channel and also on msfocusradio.org. So remember to follow MS Focus on Facebook, Twitter, and Instagram for the times and access information when this program is available. I also want to let you know that there will be many more teleconferences coming up. We're trying to give you the maximum educational opportunities during this downtime when we're all on quarantine together. So I want to say thank you to all of our callers for your participation. Thank you to those of you who brought your questions. And especially I want to say thank you to Dr. John Schafer. You obviously put so much time and care into this information, so up to date with the newest medications that were approved. We really appreciate the attention that you gave this topic. Thank you so much, Dr. Schafer.
Thank you, Casey. My pleasure.